This is Chapter 8, Nursing Care of the Family During Pregnancy. The prenatal period. This is a period of physical and psychological preparation of birth and parenthood. There's an opportunity during this period for nurses and members of the healthcare team to influence family health, for a healthy woman to seek care and guidance, for health promotion and interventions that can affect the well-being of the woman, and the health of the child and the family as a whole. Pregnancy spans 9 calendar months. It's 10 lunar months of 28 days, 280 days total. Trimesters, you have your first trimester, it's weeks 1 through 13. Your second trimester, this is weeks 14 through 26. And then your third trimester are weeks 27 through weeks 40. Diagnosis of pregnancy. Estimated date of birth. There are formulas that are used to calculate the estimated date of birth, but none are infallible. Nagel's rule is one of those formulas. You determine the first day of your last menstrual period, you count back 3 months, and then you add 7 days. An example of this would be June 14th, you count back 3 months, March 14th, add on 7 days, and this makes your due date March 21st. Adaptation to pregnancy. Maternal adaptation to pregnancy is one thing that can be easy for some and difficult for others. One must accept the pregnancy. Identifying with the mother role is something that the mother will have to do. Ordering personal relationships with others. Establishing a relationship with the fetus. Emotional attachment is something that the mother will bond with the fetus, the baby. And preparing for childbirth. Preparing things at home, preparing the other family members. Pregnancy affects all of the family members. The mother just adjusts to the changes in her body, that's one part of it, but family members must make changes as well, preparing for the birth and the changes that are going to come in the future months. Okay, let's talk about paternal adaptation. Accepting the pregnancy, there can be 3 phases of this. This is identifying with the father role, reordering personal relationships with others in the family, establishing relationships with the fetus, and preparing for childbirth. The father has to do all of these things. There's sibling adaptation if there's other siblings in the family, and then grandparent adaptation for those grandparents that are going to be new grandparents. This can be a very happy time for the family. Feelings of excitement. The new father must identify his new role and how that's going to work for him. The parents are preparing for the birth of the child, and if siblings are involved, they have to adapt to this new role as well. Women are usually very happy about the pregnancy. However, this can be a time of high emotion, so their feelings may change as the pregnancy goes on. So these are things that you have to think about, and if it's an unplanned pregnancy, these are also things we must consider. Let's discuss the goal of prenatal care, and that would be to promote the health and well-being of the pregnant mother, the fetus, the newborn, and the family. We want to emphasize on preventative care and optimal safe care throughout the pregnancy. Prenatal care is sought routinely by the woman of middle or high socioeconomic status. The primary goal, as we said, is health of the mother and the fetus. Also keep in mind prenatal care is typically only sought by middle to higher socioeconomic status, and consider reasons why people of lower socioeconomic status may not seek health care. We want to discuss women of poverty or their lack of health care insurance and how that may their access to public or private care affects their pregnancy. Lack of cultural sensitivity care and communication interferes with access to care. Immigrant women from cultures in which prenatal care is not emphasized may not know to seek routine care. Birth outcomes are less positive with higher rates of maternal and newborn complications. Problems with low birth rate and infant mortalities are associated with inadequate paternal care. You can look in your text on page 192 for more of this information. Barriers to obtaining prenatal care include lack of motivation to seek care, inadequate finances, lack of transportation, unpleasant clinical personnel, unpleasant facilities or procedures, inconvenient clinic hours, problems with child care, and personal and cultural attitudes. This information is found in your textbook on page 192. Home visits by nursing during pregnancy has been validated to be helpful. Current model of prenatal care used more than a century. Research supports a model where fewer visits for women at low risk for complications and group prenatal care is an alternative to the traditional care model. Facilities learning and encouraging discussions and fosters mutual support in this group model of care. You can see and read more about this in your text on page 193. In the initial visit with a pregnant mother, there's an interview and a discussion. The reason for seeking care should be discussed. Current pregnancy, childbearing and reproductive history is very important. Health history, nutrition history, history of any drug use or herbal use, any herbal preparations. This is very important so that we have a history on the mother and we know what may affect her pregnancy. Also, during the initial visit with the mother, a family history, social and occupational history are completed. History of any physical abuse, a full review of systems is completed. A physical examination and any laboratory tests that the physician may order are completed. We also want to get a subjective view from the woman, feelings about her health and about the pregnancy, and the nurse needs to get objective observations of the pregnancy and how the woman is handling this. During follow-up visits, typically there's an interview that's completed, physical examination is completed, fetal assessment including fundal height, gestational age, and health history is completed. This is done with every follow-up visit typically. Fetal assessment is completed, lab tests, multiple marker or triple screen blood tests may be ordered. Ultrasonography and amniocentesis could be ordered. Sometimes there's a sickle cell screening for African, Asian, or Middle Eastern heritage. HIV is strongly recommended, but all pregnant women must be voluntary. They must consent to this. Folate, CF screening should be offered. Urine specimens for culture and metabolic tests, TB testing. During the vaginal exam, smears are sent for cytology or chlamydia and gonorrhea. Scripturine blood tests may be ordered, and these are just a variety of different tests that should or could be ordered for the pregnant woman. Education about maternal and fetal changes should be provided to the woman. Education for self-management. We want to educate her about nutrition, personal hygiene, prevention of urinary tract infections, Kegel exercises, preparation for breastfeeding the newborn, dental health. We want to assess the woman's knowledge of the Kegel exercises. She needs to know what they are, how to do them, how often to do them, why she's doing them. We want to educate about nutrition, adequate oral intake of water, no smoking, no alcohol intake, adequate intake of green leafy vegetables, personal hygiene, prevention of UTIs, emptying her bladder on a regular basis. We want to educate her on all these different things. We also want to provide education on physical activity, posture and body mechanics, rest and relaxation, employment, the safety of employment if she has no physical or limitations, clothing, and travel. Travel depends on trimester and doctor's recommendations. Employment, many women work until the last day until they deliver the baby. Clothing should be comfortable and no binding. Good posture and body mechanics to help with body aches and pains from increased weight gain in the center of the body. And physical activity is generally not limited unless the pregnancy is a high-risk pregnancy. We need to provide education for self-management to the pregnant mother. We need to talk about all types of drugs. Over-the-counter and herbal medications should be stopped unless prescribed by her physicians. They are teratogenic, which means harmful to the fetus. Many medications can be teratogenic. Over-the-counter medications should always be checked with her physician prior to taking. All alcohol and smoking and caffeine are not advised during pregnancy. Immunizations with live viruses are generally contraindicated during pregnancy. An example of this is the MMR, chickenpox, oral polio. They're no longer used in the U.S., but you need to know about immunizations. Tdap is recommended with each pregnancy per CDC guidelines. Woman needs to know signs and symptoms of complications of pregnancy. The woman and her family should be provided with a printed list of warning signs. You can find this on Table 8.2, page 198 of your textbook. These are all things that we need to be educating the woman and her partner. We need to know the signs of preterm labor and educate the pregnant woman on the signs of preterm labor. How to recognize preterm labor usually occurs after 20 weeks and before 37 weeks of gestation. Usually consists of uterine contractions that, if untreated, will cause the cervix to dilate and efface earlier than normal, resulting in preterm labor. Check your contractions for 1 full hour from the beginning from one to the beginning of the next. Labor is regular, frequent, and hard. May also be felt as a tightening of the abdomen or as a backache. If this continues every 10 minutes for 1 hour, you need to call the doctor or the midwife. You can look at page 214 in your textbook for more information on preterm labor. We need to provide sexual counseling to the pregnant woman and her partner. This is when the nurse provides information to the couples about alternative behaviors. She educates the couples about misinformation and reassures them that sex is actually safe during pregnancy. Many couples do change their sexual habits when they become pregnant. Typically, a woman's libido may be depressed during the first trimester, but it increases during the second and third trimesters. Different cultures have different do's and don'ts about sex during pregnancy, and that's okay. Many couples try different positions due to weight gain and comfort. Sexual intercourse is safe as long as it's comfortable. There's really no correlation between sex and miscarriage. You would, however, abstain if you were having abdominal cramping or bleeding, and if that happens, you need to seek medical attention. You can read more about this on page 214 in your textbook. Although pregnancy is considered normal by many, certain practices are expected of women of all cultures to ensure a good outcome. Cultural prescriptions tell women what to do, and cultural prescriptions establish taboos. The purpose of these practices are to prevent maternal illness caused by a pregnancy-induced imbalanced state and to protect the vulnerable fetus. So there are different beliefs culturally in many cultures on emotions, clothing, physical activity and rest, sexual activity, and nutrition. You may read more about this on page 216 and 217 of your textbook. The age of the child-rearing couple may have a significant influence on the physical and psychosocial adaptation to pregnancy. Younger moms, teen moms, are much less likely than older women to receive adequate prenatal care, oftentimes giving birth to low birth weight babies. Women older than 35 years of age, multiparous and nulliparous women, oftentimes have other difficulties, such as adverse potential outcomes. They oftentimes are at risk for chromosomal abnormalities, also low birth weight infants, preterm babies, multiple gestations. They also have an incidence of malpresentation that is more common, cesarean birth, also embolisms, hypertension disorders during pregnancy, hemorrhage, and cardiomyopathies and stroke. Click on the link provided to watch the nurse's role in prenatal care. Click on the link provided and watch the YouTube video and be prepared to discuss the importance of the nurse's role in class. Multifetal pregnancy. Twin pregnancies often end in prematurity. Rupture of membranes before term are common. Congenital malformations twice as common in monozygotic twins as in singletons. No increase in incidence of congenital anomalies with dizygotic twins. This information is found in your textbook on page 219. Multifetal pregnancy places the mother and the fetus at a higher risk. Maternal blood volume increases, so does cardiac output. The workload of the heart is increased. Anemia often develops because there's a greater demand for iron with two fetuses. Placental previa is more common due to the larger size of the placenta for the two placentas. Congenital malformations are more common, and there's two vessel cords, one umbilical artery. Remember, multifetal pregnancy, the probability is increased by history of dizygous twins and female lineage. Use of fertility drugs increases it greatly. Rapid uterine growth for weeks of gestation. And polyhydramnios, excessive amniotic fluid. That's a sign that there may be a multifetal pregnancy as well. Multiple fetal pregnancy probabilities increase when there's a palpation of more small or large parts than expected, asynchronous fetal heartbeats, or more than one fetal electrocardiographic tracing, and ultrasonographic evidence of more than one fetus. Multifetal pregnancies can place a large strain financially and emotionally on families, and sometimes they will need counseling and assistive services. With multifetal pregnancies, prenatal care given women with multifetal pregnancies includes changes in the pattern of care, amount of weight gained, nutritional intake, and how it's observed. Uterine distention can cause severe backache for these women. The care of these women and their pregnancies is different than a traditional pregnancy. These women are seen more often, and they are watched very closely. Multiple newborns may place a strain on the couple's finances, space available, workload, the woman and family's ability to cope. Lifestyle changes are necessary typically. National organizations are available for support. Prenatal education goals. We want to assist individuals and their families to make informed, safe decisions about childbirth. We want to assist them in their comprehension of the long-lasting effects and empower them to make good birth decisions so they can have a good birth experience. Ideally, this begins in the preconception period, and then this goes through the pregnancy until the birth of the child. Components of the early pregnancy classes. Early fetal growth and development is discussed. The physiologic and emotional changes of pregnancy in their body. Human sexuality, nutritional needs of the mother and the fetus are discussed at length. Environmental and workplace hazards are also discussed. Components of the late pregnancy classes, we discuss management of discomforts in labor, relaxation techniques, imagery and visualization, biofeedback, learn to control your body impulses, breathing techniques, pharmacologic interventions, IV medications and epidurals, and the things that they may need when giving a birth and during labor. Perinatal care choices. You have many choices: physicians, nurse midwives, direct entry midwives, which are unlicensed or uncertified, gained experience through self-study, independent midwives, or doulas, which are non-medical birthing partners. This information is found on page 221 in your textbook. Birthing plans. Birth plans are discussed early in the prenatal visit. Questions to consider when writing out a birth plan: partner's participation, birth setting, where do you want to have the baby, labor management, how do you want to manage your labor, do you want drugs, do you not want drugs, do you want an epidural, do you not want an epidural, birthing position, immediately following the birth, contact with the baby, breastfeeding, postpartum care, what kind of care, mom, baby, family attendance, are there other children going to be in the room? This is all information that you want to consider prior to birth of the child. This information for making a birth plan is page 222 in your textbook. This is one example I have for you of a birth plan that somebody has completed, and I've attached to the PowerPoint. Again, when discussing your birth plan, birth setting choices: labor, delivery, recovery, postpartum, birthing rooms, birth centers. Home birth is an option. Factors increasing the safety of birth at home. You need to discuss those and consider those. Again, look in your text, page 222 to 223. These are just pictures of different birthing beds available to pregnant mothers.